Everyone.
Can everyone hear me?
Good morning, everyone. Today I shall be discussing the importance of the diagnostic manuals we bring in every morning to understand the signs and symptoms a patient have presented with. While I'll be talking for the motion for these diagnostic systems, my senior Dr. Veena will be talking against the motion. I would start with a quote that science is the scientific classification of experiences. Psychiatric taxonomy or psychiatric nosology is a process by which complex phenomena are reduced by rearranging into categories based on shared characteristics. There are four approaches: the etiological approach, the descriptive approach, the categorical approach, and the dimensional approach. Etiological approach is to find reason for set of symptoms. To understand mental illness in all its a complexity, we must discover how all forces from individual goes into their social culture and interact over time. This approach was first used by Paracelsus in the 16th century. He divided into three types. That was Vaccania, that is disease caused by poison, which we now use as substance-induced disorder. Insanity, disease caused by hereditary, like schizophrenia and bipolar. And lunacy, which is influenced by mood. The descriptive approach is approach to classification defining disorder based on the clinical description of the presenting symptoms. This approach came to force by the work of the 19th century, Emmeline Kaplan, which forms the basis of the current DSM classification. The categorical approach involves the assessment of whether an individual has a disorder on the basis of the symptoms and characteristics. This approach is used in DSM and ICD. DSMs name the disorder and describe them in specific terms, while ICD identifies the symptoms that indicates the presence of these disorders. The dimensional approach is symptoms of the disorder exist on dimension, which is in a quantum from normal to severely ill. This approach decides the degree to which a particular characteristic is present. In present, DSM-5 recognizes the need for this approach. Like in substance use disorder, a quantum or a dimensional was included, that is mild, moderate, and severe, which is useful in indicating the severity of the disease. This approach is useful to represent the comorbid disorders, like an individual who presents with depression, anxiety, and social avoidance. The historical aspects of these diagnostic systems was even recognized in 377 BC. In ancient Greece, Hippocrates recognized the need for these classification systems. He can be credited with the first classification, where 6 conditions were given, like mania, melancholy, epilepsy, and hysteria. In 1840, US recognized the need for a census of mental illness, including the category of idiocy and insanity, which later expanded to 7 categories, that is mania, melancholy, and epilepsy. Even in the Second World War, it was recognized to have this demand for systems for assessing the mental illness of these soldiers. In this scenario, ICD-6 was born under WHO, which for the first time included the mental lives. The first version of DSM was influenced by the American Psychiatric Association as well as ICD-6. DSM-1 and DSM-2 were provided with a system for gathering of national statistics. DSM-3 took a descriptive approach to mental disorder. DSM-3 coincided with ICD-9. It was defined with a list of observable signs. Example, if weight loss of 25% is over the original body weight, the patient's reported symptoms, number of signs and symptoms to be present, the duration and the course of the illness were defined. DSM-3 was helpful with medical insurance companies for reimbursement for care. It also became the standard for US federal agencies to test for new drugs. The DSM-4 was organized into 5-part axial systems. Axial 1 included all psychological diagnostic categories. 2 included the personality disorder and mental retardation. 3 included the general medical condition, and 4 included the psychosocial and environmental factors, while 5th included the global assessment of functioning. The DSM-5 removed these 5-axis frame, making it a close structure to ICD-10 diagnostic system. The ICD-5 use a diagnostic approach. The APA's DSM-5 task force adopted to revise order criteria for cross-cultural data warranted it. One criteria for diagnosis of social anxiety disorder and fear of negative evaluation was broadened to include a separate section that is a culture-related diagnostic issue. Mental retardation was removed and intellectual disability was added instead. The systems of classification in psychiatry are ICD by WHO and DSM by APA, which I have just described in the historical aspects. The other classifications are Chinese classification of mental disorder, Latin American guidelines for psychiatric diagnosis, and research domain criteria for by NIMANS. Research domain criteria is offering a neurobiological explanation of psychiatric disorder, including the genetic and other factors that influence the neurotransmitters and neural circuits. It incorporates an explicit dimensional approach to the psychopathology. Example, in schizophrenia, identifying a biomarker such as the cerebral white matter abnormality when a patient presents in a pre-psychotic symptoms would warrant early intervention of the patient. Now coming towards the advantages of these diagnostic systems. Since the underlying pathological process is not possibly known of all mental disorder, criteria is the best tool to describe how mental disorders are expressed and can be recognized by others. The introduction of an agreed psychiatric classification system has enabled researchers and psychiatric professionals worldwide to communicate about diagnosis in a standardized manner, where initially these professionals has used same words but with wide variable concept and content. This was first demonstrated by Wings, who compared rates of schizophrenia between UK and US by using these standardized manuals. This, this situation demanded for a need for standardization. For example, if we diagnose a patient as having major depressive disorder, with the help of this classification, it is easier to convey that it is not a normal kind of mood function, and hence mood is the central aspect of the presenting problem, and it also tells the severity of the disease. This helps us to convey a great deal of information in just a few words. It also helps in psychoeducating the family and the patient about the illness as well. And in these organization of this and in this organization of disorder into diagnostic classes, which allow the mental health professional and research to lay out an effective plan of action. Because of these simplified classification systems, diagnosis can be performed efficiently and accurately without requiring extensive research and expensive equipment. Gives a person an advantage of all social and medical benefits with such an illness. Also, medical services are reimbursed by health insurance providers only on the basis of these standardized diagnosis. The classification have been the pillars of a residency program. It is the core of the learning for the upcoming psychiatrist, helping us with the phenomenology and different diagnoses. They form the basis for the teaching as well. An important aspect of having the standardized classification system is in regard with the legal systems. The court can make an informed forensic decisions based on these criteria. These systems help in healthcare epidemiology to determine the incidence and prevalence of the disorder. WHO is responsible for reporting the health statistics based on these ICD to WHO. One example of how this health statistic is being used in the global burden of disease study, they showed that mental and behavioral disorders account for 6.6% of the total global disease burden as measured by daily. The integration of these systems in a clinical process have helped with the management of the health service, the development and integration of electronic information infrastructure for health core. Example, the electronic health records and evidence-based clinical guidance. The application of ICD in healthcare system are also governed by the national and the local laws, as well as by the health system policies. The WHO organization, the World Mental Health Composite International Diagnostic Interview is a comprehensive, fully
Dr.
structured
Rakesh,
interview.
please wind up. Your time is exceeding.
Okay, sir. This interview is designed to be used by the trained interviewers for assessing the mental disorder, which is also according to the criteria of the ICD and DSM-10. These classical systems were a major step forward, introducing order in a field that had previously been chaotic. I would like to end by telling that what our medical colleagues have are numerous tests to support these diagnoses. What I have when I enter the emergency to explain to my medical colleagues when a substance is in a dependence use or in a harmful use, or to tell when a patient is experiencing a depersonalized experience, are these numerous diagnostic systems which help me to place a patient in a specific criteria. I would like to say that these manuals are I would like to say that these manuals bring one of the star tools which we have. We do not enter battle without them. Thank you.
Thank you, Dr. Rakesh. And now we have Dr. Veena, who will be debating on the against the motion.
Yes. Good morning, all. I'm Dr. Veena, Senior Resident Psychiatry, and I would be speaking up on the topic Diagnostic System in Psychiatry against. At the onset, psychiatric methodology over the years, classification of psychiatric disorders considered the course and response to the therapeutic procedures, and if known, the etiology and pathogenesis of the symptoms. It was based primarily on presenting signs and symptoms. Traditional
the slides, the board slides are coming. I think Dr. Aditi's slides is visible.
So now is it fine?
No, I think we'll have to stop and again share. I'm just seeing Dr. Aditi's advantages screen only. Slide number 7. Yeah, now I can see. Okay.
Traditional systems were based on clinical intuition, expert classification influenced by a few essential features, and heavily influenced by priori top-down approaches. Talking about the pre-diagnostic system era, in 1844, psychiatry was recognized as a specialty in US. Only asylum psychiatry were practiced. Second World War exposed the realities of the psychiatric diagnosis. Until 1950, we have only 5 official diagnostic systems were practiced. Now coming to the roadmap of DSM, in pre-DSM era, it was influenced by Triplett. DSM 1 and 2 were based on psychoanalysis. DSM 3 led to the recognition of neo-Triplinian, but psychoanalysis again came into the fore in 4th edition. DSM 5 was, on the other hand, was influenced by neurosciences. DSM 1 and DSM 2 consisted of 122 and 193 diagnostic categories, respectively, were etiology-based and had poor reliability. In 1970s, saw the proposal of Renal diagnostic criteria and research diagnostic criteria, and under the leadership of NIMH and the famous Robert Spitzer, DSM-3 was launched, which was termed as Return of Neotroplanian. DSM-3 was proposed in 1970s and was supposed to be more reliable, valid, and consistent with international approaches, but it led to unintentional consequences. Validity was sacrificed to achieve reliability. DSM had total authority in training programs in healthcare delivery system, mainly in the West. There was steady decline in the teaching of careful holistic clinical evaluation. Students were taught to memorize DSM rather than to learn complexities, which led to the death of phenomenology. Uh, in 2013, DSM 5 was launched and it had 541 diagnostic categories, which embraced dimensional approach and introduced the concept of spectrum disorder. But DSM-5 came into a lot of criticism. At times, it used a dimensional model, but kept categorical models at key places, thus demonstrating a double standard. There was a rise in both the number of mental disorders and the scope of their definitions, implying a growing and unjustified medicalization of multiple areas of daily life. There was a huge funding from the pharmaceutical industry and a huge media frenzy behind it. The introduction of women-centered diagnosis also led to the criticism from different agencies and forums across the world. Talking about challenges to the classification, DSM and ICD have been blamed for frequent changes and too many additions. As now we talk about the basic challenges of classification. The brain is a complex.
Dr. Veena, your voice at times is not audible.
Sorry, sir. My voice is. Hello.
Now it's okay. Now it's better.
Okay. Now we talk about the basic challenges to the classification system. The brain is complex and largely inaccessible. There are difficulties in modeling complex human systems and behaviors experimentally. Inclusion of several factors and classification lead to significantly more divergent attempts to classification. DSM and ICD have been blamed for frequent changes and too many additions, as researchers need stability in diagnostic systems for evaluation of psychopathology. Clarifying concepts of risk, prodromal disorder, and mild disorder needs to be done. The use of broad versus narrow etiology and using contextual exclusion to increase validity has resulted in a dilemma, as well as subthreshold diagnosis and the missing dysfunction in the other specified disorders are added to the confusion. Talking about culture and psychiatric diagnosis, clinical problems list include social problems, interpersonal conflicts, and existential dilemmas. Religious and spiritual dimension of life impact human experiences, beliefs, values, behavior, and illness pattern across the world. Example, high rates of dissociative disorders, possession and trance states, and conversion disorders in Indian patients. DSM-5 and ICD-11 cultural incorporation is still poorly done. A cultural access might have been proposed. Now, issue of value judgment has not been addressed in the definition of mental illness since DSM-3. Societal view about a particular thing keep on changing. For example, homosexuality was a disorder during the time of DSM-1 and 2. Now it is not. Meaning, value judgment of a particular thing keeps on changing. It also means that what dysfunction and harm means would keep changing as per the value judgment of the society. Sadler, in his influential book, Value and Psychiatric Diagnosis, stresses the same issue, calling all the diagnostic system till now fundamentally flawed for not valuing cornerstones of the psychiatric diagnosis, which are aesthetics, how people prefer things to be, epistemology, research methods we prefer, ethics, morals of classification, ontology, fundamental nature of the psychiatric disorders, pragmatics, usefulness of classification. Sadler's book legitimizes philosophical discourse in making psychiatric diagnosis. Now to conclude, issue of heterogeneity, comorbidity, fuzzy boundaries between normal and pathological, and lack of specific biomarkers plague the psychiatric nosology. Solutions to overcome the criticism of current nosology are proving elusive. Instead of narrow models primarily emphasizing etiology, we must allow for the impact of both empirical and pragmatic factors. So coming to end, diagnostic systems have their flaws. No system is perfect. We need them, but not at the cost of psychopathology. Thank you.
Thank you, Dr. Veena. That was very nice. I think that you have finished in time. Although there is a problem in audibility because there is some noise disturbance coming from background also. So I will ask Dr. Aditi now if you can give a rebuttal on the points raised by Dr. Veena on the lacunas in the diagnostic system. And since Dr. Aditi, I think, took longer time in her presentation, so
Yes.
2 minutes time for a rebuttal.
Yes. I would like to start with the line which has already been displayed on the screen, that the diagnostic system have their flaws. No system is perfect, but we need them. We do need them because as Dr. Veena said in the presentation, that due to lack of biomarkers and no lab test or blood test or any test to determine the presence of a mental disorder, we clinicals rely on the patient's self-report with themselves, self-report, which itself is a subjective approach. As ma'am said that in DSM-5, there has been a rise of mental disorder. It should be noted that the list of mental disorder in DSM-5 includes some conditions that the general public doesn't even realize is a disorder. Example like insomnia or sexual dysfunctions are also now considered as mental disorder in DSM-5. Only asylums practice psychiatry is wrong. As I told in my historical aspect, the World War II also recognized the need for these systems, that the soldiers who were sent to fight in these situations needed to be mentally evaluated if they were mentally fit to enter this war or not. The main focus of the PPT was on the criticism of DSM-5, which is not the end of a diagnostic systems. It is a change, and change is a path to growth. Uh, the,
Is that all?
the diagnostic system is based on systems, not cause, simply because specific cause is not known. It is not necessarily known the cause of a problem in order to solve it. The treatment and the medications help many people, even though we do not know the cause of the disorder. That does not mean we will not treat them because we do not know the cause and will not place them in a criteria as the etiology is not known. Thank you.
Thank you, Dr. Aditi. Dr. Veena, your rebuttal, you have 3 minutes. What do you say to the points raised by Dr. Aditi that the biological markers do not help or the investigations do not help in actually ascertaining the disorders?
So as DSM and ICD have been blamed for frequent changes and too many additions, and researchers need its stability in the diagnostic system for evaluation of psychopathology. We don't have a reliable system which we can keep. It kept on changing because of issue of value judgment has not been addressed in our diagnostic system in the definition of mental health since DSM-3. So society view about the particular things keep on changing. For example, homosexuality. I given the
Your
example.
voice is cracking up. If you can come closer to the mic, please.
Sorry, acha. Like societal view about the particular things keeps on changing. For example, homosexuality was a disorder during the times of DSM 1 and 2. Now it is not considered as a disorder. So value judgment of a particular thing keeps on changing. It also means that what dysfunction and harm means would keep changing as per the value judgment of the society. By default, there can be no final version of any DSM or ICD, like, as stressed by Sedler also. So we need a always we have to keep a change on the diagnostic system, and diagnostic system leads to unjustified medicalization also. So and NIMH, which introduced DSM-3, and now it outrightly rejected DSM-5 as it did not go with its agenda of acknowledging underlying systems, genetics, and neurosciences, and proposed their own classificatory system. Uh, RDoC, which conceptualizes mental disorders as disorders of brain circuit. So there is always a need and to change the diagnostic criterias and according to the value judgment. So
Okay, thank you.
yes, sir.
Thank you.
Thank you, sir.
Good morning.
Morning.
Sir, I think both of them have done a very good job. I think we are hearing Dr. Veena for the first time. Then she has spoken very well. I think she should speak more frequently in subsequent endeavors. And both of them have actually put up this debate. This debate is a very important debate because someone is speaking against the diagnostic systems. That means we'll crash the foundations where we are working on, because an NIMH tried to introduce this RDoC, but RDoC has been standing still for the last 10 years. This has made almost no progress. Sorry. And the most important foundation where it started was common language, but the basis was etiology, and this etiological movements, the etiological movements have not been taken. It has actually not progressed. And etiopathogenesis, we hardly struggle, except from dementia. We don't have any etiopathogenesis of psychiatric disorders. And I think these points have been put uh, forth in this debate. So I think both of them have done a very good job. Hopefully, we
Right.
can have these kind of debates more frequently, sir.
Sure. Personally, I was like, for me, because there was a lot of reading by some background also, system wise also, I was not able to listen to the debate properly. More fault of my system, maybe. I'll get headphones next time on. Yes, the debate is very, I think, pertinent. Any other person has comment? Any attendee wants to put his comment on this? Okay, so yes, of course, we need the classificatory system, as I think the advantages have been very nicely put by Dr. Aditya, and Dr. also has put up this. The main problem, I think, the current diagnostic system is the revisions that they are going through. But there is a lot of problem in that. Am I audible?
Yes, sir.
Okay. So the problem is revisions, where
Yes, sir.
there is a lot of interventions from the patient groups, the caregiver groups, who are pressing on for some disorders to be included, some disorders to be excluded. And Then there is among the psychiatrists also there is not unanimity. Dr. Veena did raise this. NIMH, they have rejected DSM-5. They just given their own diagnostic criteria. So that because there is no unanimity among the psychiatrists, it gives an opportunity for other say outsiders to raise fingers on this diagnostic system. There is some amount of, I think, rigidity on the part of uh, the classic, the psychiatrists also to include etiological factors or diagnostic factors, biological factors into the diagnostic category. We in our clinical settings use these points. For example, family history. We do use family history. We do take that into the inclusion while like it into consideration while we are making a diagnosis, but it does not find mention anywhere. For example, in dementia, imaging and other investigations, these could be included in the diagnostic system because the other diagnostic categories, the criteria that we have, they are also not that, you can say, pathognomonic. Presence or absence of one symptom is not equal to a diagnosis. So we could include these factors into the diagnostic category, which we are already doing, and that would be more meaningful rather than just changing the you can say signs and symptoms. So anyway, nice debate, and hopefully we'll have it in better suitable circumstances. Our seminar room is under renovation, and we are working on different systems so that did affect a little bit of our academic experience. So
Yes.
thank you everyone, and I think we can give the meeting here.
Thank you, everyone.
Thank you. It's